So hi everyone, thank you very much for this invitation. This is David Smadja from Tel Aviv. Very happy to be part of this AECOS webinar, and very happy to share with you this challenging case that will take us through the many surprises that the corneal epithelium has to offer to us after refractive surgery procedure. So those are my financial disclosure. Nothing is related to this talk today. And as any challenging case, it has to start with a patient that is usually either lawyer or a physician. So today we have a physician, a gynecologist, 30 years old, coming for a regular screening examination. No Collar family history, regular myopic astigmatism in both sides, as you can see here, and normal slit lamp examination with no staining, clear cornea. So we move forward with the examination. We can have, we can see here normal topography in both sides with fairly good central corneal thickness, 570 in both sides. We have a normal epithelial OCT as well with the physiological pattern that is well preserved. And you can see this slight thickening of the inferior part of the epithelium. So we decide to go for a LASIK surgery, a fairly good candidate for that. And we have a completely uneventful LASIK surgery. You can see here a nice docking of the surgery. We have atraumatic docking in both sides, first attempt with a nice flap cut here. The LASIK was completely uneventful. In this case, you can see a nice docking, first attempt in both sides, no epithelial traumatic trauma in both sides. However, when we were lifting the flap at the second eye, the left eye, despite an uneventful procedure, at the time of the flap repositioning, I could see a small area of epithelial weakening and sloughing when I was putting the flap back. So just to make sure, I put a bandage contact lens until the next day, and so far I was not seeing any issue with that. However, at post-op day 1, the surprise begin. We have in the right eye good outcomes, 2015, first day. However, in the left eye, we see another treatment with plus 1.25, uncorrected 20/30, and patient can see only 20/25. At this point, I was thinking maybe it could be a slight edema on the corneal periphery because of the contact lens. But slit lamp examination was normal in both sides, no epithelium irregularity or staining, so I keep following with this patient. And we get 1 month, nothing is getting better. Uncorrected vision stay at 20/30, patient cannot still get through 20/20. He's stuck at 20/25 with 1 diopter of withdrawal astigmatism, and interestingly, this astigmatism is located on the cornea. You can see the topography, and when I look at him at the slit lamp, I can see this irregular epithelium observed with negative staining right on the pupillary area. And interestingly, the epithelial map and distribution can clearly show some irregularities with thinning of the epithelium right at the axis of the astigmatism. So probably the source of this astigmatism after 1 month. And you can see these optical quality findings showing a very large scattering on the left with a poor quality of vision and high PSF here that support the limited best corrected vision in the left. So at this point, decided to take him to the OR for a second one. We are the 5th week. I take him to back to the OR. I'm doing a large epithelial scrapping on the left. Put a bandage contact lens and add some doxylin once a day, vitamin C, tapering down of steroids and preservative-free artificial tears. And here we go, the surprise continue. We are now 3 months after the scrapping.
Patient is getting worse actually. The vision is only 20/80 and has a huge myopic shift of 2 diopters. And when you look at the topography pre and 3 months post scrapping of the epithelium, you can clearly see that the K indeed increased by 2.2 diopters. So that explains this myopic shift. So what is really happening in this patient? The secret will be told in a second. And here we go. You can see here the epithelial map of the patient. So the secret is here right in front of us in the epithelium. And I'm going to show you in another perspective what happened in this epithelial mapping. You can see a 5 to 7 millimeter optical zone with an average of 61 micron of epithelial thickness. And it gets thicker between 2 and 5 millimeters. And we have this little bump at the 2 central millimeter. So overall, we have a 19 micron difference from 2 to 6 millimeters, which create this kind of plus lens at the central part of the cornea. So we decided to run a monoline formula on this epithelial map to see whether we could find the source of this myopic shift on the corneal epithelium. And guess what? 19 micron would correspond to 1.6 diopter of myopia over a 6 millimeter optical zone. So we decided to take him back to the OR for a third round of treatment. So we are week 17. We start by scraping manually the epithelium to remove this induced epithelial hyperplasia that was likely inducing this myopic shift. And I'm adding a dry PDK, about 10 micron, to treat any possible underlying basement membranal dysfunction, and adding also wet PTK to smoothen a little bit the stromal flap irregularities, and finally add a PRK of half diopters with 40 seconds of mitomycin C at the end of the procedure. Now, to stay cautious after the correction, I keep the bandage contact lens this time for 1 month with a taper down of steroids and doxylin kept in place. And once the contact lens was removed, I added the autologous serum 50% for an additional 2 months, and I sent him for genetic testing as well to foresee what could happen also in the other eye and trying to understand what happened to this patient. So interestingly, we sent for the Avellino testing that could test 35 corneal dystrophy there, and he came back positive to 2 main families that were interesting for us: a mutation in gene of TGF beta family and another mutation in the keratin gene family. Now, keratin is interesting because there are proteins that are responsible for the epithelial cells integrity, and mutation of those genes were seen to be associated in a few epithelial dystrophy. So finally, happy end. 3 months after this third run in the OR, patient was finally on target and happy with the 20/20 vision, just with a combination of PTK, I remind you, and a half diopter only of myopic correction for a -2 diopters of correction. So it was indeed related to this epithelial redistribution and remodeling after the surgery, a well-centered ablation, and we clearly see here the improvement of the epithelial distribution. However, that was a very short grasp period that we have, and back to the beginning at this time, at the 6-7 months after this initial surgery. But at this point, it was for the right eye with irregular epithelium. We were actually looking for that, and we told the patient as well after we received the genetic testing. We told him that it could happen also in the right eye, and you can see the huge difference between the right and the left epithelial mapping between the 2nd and the 7 months.
The last important point is that sometimes genetic testing during refractive surgeries actually might help to foresee some of the potential complication of the patient, especially when it comes in one eye. Then it might help to figure out what might happen in the second eye. So thank you very much for your attention.
Perfect. Thank you so much, David. It was really interesting case. And I think the magic of how the epithelial cells communicate together to be able to share the information how to smooth the surface is really magical, and whoever will discover how they communicate will deserve the Nobel Prize, correct?
Yeah, definitely.
That waits for you. And before you discover that, I have a question. It's also, I think, dependent on the resolution of our OCTs, and some OCTs cannot really, create quality enough data for the epithelial thickness map. Which OCT do you use, and how do you see the technology in this aspect?
Oh, that's a great question. So actually, I'm using a couple of OCT in our clinic. The clinic is spread over a few different places. Now, it's interesting what you said, because we are currently running a study comparing the numbers between the Cassia OCT epithelial map and the OptoView as well. And indeed, the numbers are not completely the same. But the one thing that is very important, I think it's the same in looking at corneal topography. The first thing that has to be important in the OCT epithelial map, for those that are using that, is the pattern of the epithelium. And pattern is extremely important, because that might raise suspicion or that might remove some suspicion. But it can definitely give some expression of what is happening in the patient eye. As far as the numbers, it might be important if we want to run some formula and get some an optical feedbacks of what the epithelial map can have as an influence on the corneal on the cornea of the patient and the refraction of the patient. So those are two main comments between the number and the pattern.
David, I really liked your presentation. It was very nice. There's a question. I'm suffering or I'm dealing with the same problems as you mentioned, and comparing the Cassia and the OptoView, and I truly support you. The question is, how do you deal with a change of epithelium thickness during the day? I don't know if you realized, if you measure the epithelium thickness map in the morning of the patient, it's a little bit different than in the evening or in the afternoon. How would you deal with this?
You're completely right about the change in the epithelium within the day, but most of the time it might change the numbers. Usually the pattern is preserved, but for now, for decision making, at least the pattern first.
Could I ask a question? David, congratulations on that presentation, and I'm going to be one of your strongest supporters. I'm going to be strongly rooting for you at the Nobel Committee. All right. But while we wait for that, I have a question. I think it's really amazing, this optical power map. I wanted to ask you, in a patient with a regular epithelium, what is the power that you expect from the epithelium? Is it just about, let's say, taking the Monellin formula? Does it come to 3 diopters, 4 diopters? How much would it come to?
That's a great point, because if you see if you see the regular epithelial map, there is a very low variation. You can see usually a difference between the center and the inferior part. Most of the time, because of this eyelid, superior eyelid pressure, you might have some thickening of the epithelium in the inferior part, but you still see a very low variation in terms of numbers. The color might change slightly, but as you saw in this patient, you might have a small variation of something about 5 micron. Now, right after the surgery, it's very interesting to see that some of our patients after myopic surgery are ending to be plano. But if you look at the epithelium is looking like a plus lens for most of our myopic ablation. So what we are starting to do now is to look at our PRK patients during the first week to see how patients that is plano after a few months end up to be plano, but with a plus lens on the top of the on the cornea. So it might be that some of the previous calculation to make sure patient can be plano might make them a little bit hyper up to end up to be finally plano. So that's a very interesting new side that we have right now, and probably the source of some of the hyperopic surprise we might have in some of the enhancements. So
David, I
Great.
wanted to just make a comment and ask you a question. The comment was that the MS39 OCT from CSO is, in fact, the epithelial profile map has refractive power. And the refractive power on a normal cornea is 0. The epithelium has no refractive power if it's, the same thickness everywhere. There's only refractive power if there's a differential from center to edge. The question I wanted to ask you, I first wanted to say that I think you managed the case really well by not doing a refractive component so early on. I've had cases that are behaving strangely, and I've waited and I've done an epithelial map and a topography and a refraction on a monthly basis and seen changes in one case up to 8 months. Mostly it's done by 3. In the odd case, maybe 6 months. And this one case took 8 months to regularize. So it can take some time. The question I wanted to ask you, because your conclusion was that some cases may do well with genetic testing. If you look back at this case, was there anything in this patient's history to make you think you would have done genetic testing for her?
It's a good point, because I'm usually running a lot of tests before refractive surgery, epithelial testing, and I could not see anything weird on the epithelium. The patient is also physician, so we have a questionnaire to ask for any type of genetic disease or something in the family. Nothing pop up there. The optical quality map were pretty good at the beginning, so sometime if we have some early change in the optical quality, it might be something true. But I can tell you that what I'm doing, so I haven't seen anything. But since 1 year, and we are right now running a very interesting study for anyone that has the Pentacam. We are using for every patient, we are using the densitometry map of the Pentacam that is very sensitive to look at very early sign of change in the epithelium, cyst, or some kind of subclinical scattered. So I encourage you to look back at the Pentacam of the same patients and look at the densitometry map if you do not have some cyst. It's very sensitive and it's very interesting to look at that. So genetic testing, I think it's nice, because sometimes it can help to reveal something that we do not have on the clinical part. So
very interesting, David. So I think it's a great topic, epithelial thickness map. So can we all agree that OCT epithelial thickness map has become a part of routine keratoconus diagnosis, and its importance is rising in other indications also?
Absolutely. Absolutely.
It also should be a base examination for pre-refractive or laser refractive patients. I mean, we should not overcome this. I mean, it's very, very important. Many keratoconic patients actually act like normal patients, normal corneas, and they're at the very beginning or very early stage of the keratoconus.
I would end this not to, I think we all agree that epithelial map is a crucial tool in refractive surgery, but I really hope that we're going to start to look more at the optical influence of the epithelium. And I really hope that the next chapter with all the scientists in refractive surgery and cataract surgery will be also there to improve calculation for cataract, and especially for cataract after laser vision correction. I think we have to look deeply into this layer, because it might help us in getting more accurate outcomes.
David, you are just opening so many Pandora's boxes. Because I mean, when you talk about the attention we should give to epithelium, then it absolutely hand in hand goes with a tear film. I mean, that's like it's like eating without cutlery. No, yes, you can eat with your hands, but you better eat with your cutlery, right? I mean, when talking about epithelium, we need to think also about the tear film.
Definitely.
Okay, precision, has no limits in refractive surgery, as I hear here. I think that was a great case, great discussion.